Welcome to our channel Medicine A to Z. Today we are going to discuss about nonspecific interstitial pneumonia, or NSIP. Definition: nonspecific interstitial pneumonia is a chronic interstitial pneumonia that is lacking the histopathologic features characterize usual interstitial pneumonia or any other specific interstitial pneumonia. Epidemiology of nonspecific interstitial pneumonia, or NSIP. NSIP not clearly associated with an underlying cause typically occurs in middle-aged females who are never smokers. On the other hand, NSIP associated with connective tissue disease has an equal distribution between males and females. Now, let's delve into the prevalence of NSIP compared to other interstitial lung diseases. NSIP accounts for approximately 14% to 36% of interstitial lung disease cases. In contrast, idiopathic pulmonary fibrosis, or IPF, comprises a larger proportion, ranging from 50% to 60%. Desquamative interstitial pneumonia follows, accounting for about 10% to 17% of cases. Lastly, acute interstitial pneumonia represents a smaller fraction, approximately 2%. Etiology: NSIP can be idiopathic. It has also been associated with many medical conditions like rheumatoid arthritis, Sjogren's disease, systemic sclerosis, scleroderma, ANCA-associated vasculitis, polymyositis, dermatomyositis, HIV infection, interstitial pneumonia with autoimmune features, hypersensitivity pneumonitis, drug-associated NSIP, flecainide, amiodarone, methotrexate, carmastane, nitrofurantoin, statins, and chlorambutyl. Pathogenesis. The understanding of the pathogenesis of idiopathic NSIP and other idiopathic interstitial pneumonias, IIPs, is evolving. Pathophysiology of the NSIP includes epithelial injury, dysregulated repair, involvement of the immune system based in the presence of lymphocyte in the alveolar septi and bronchoalveolar lavage, and abnormal fibroblast, myofibroblast function, leading to excess collagen deposition. Clinical features: dyspnea and cough that have developed subacutely over weeks to months. Depending on whether an underlying connective tissue disease is present, patients may also report dry mouth or eyes, joint pain or swelling, muscle tenderness or weakness, Raynaud phenomenon, rash or other skin changes, or neurologic symptoms. Occasional patients with apparent idiopathic NSIP may develop connective tissue disease after the diagnosis of NSIP. The majority of patients have bibasilar crackles, but only 10 to 35% have clubbing. How to assess a suspected NSIP patient? Patients should be asked about exposure to airborne organic antigens, e.g., barns, birds, hot tubs, humidifiers, mold, plastic epoxy manufacture. A complete list of current and recent medications should be reviewed for agents associated with NSIP. Patients should be asked about any history of radiation therapy, and risk factors for HIV infection should be assessed. Laboratory tests often include anti-nuclear antibody, rheumatoid factor, and anti-citrullinated peptide antibodies. These tests help in identifying underlying autoimmune conditions that may be associated with NSIP. Next up, we have pulmonary function tests, a cornerstone in assessing lung function. These tests include lung volumes, diffusing capacity for carbon monoxide, and a 6-minute walk test with assessment of oxygen saturation. But let's not forget the importance of imaging studies in the diagnostic process. However, for a more detailed evaluation, high-resolution computed tomography, or HRCT, is indispensable. Lastly, we have bronchoalveolar lavage. However, it's important to note that BAL findings in NSIP are nonspecific, and BAL cell counts cannot reliably differentiate NSIP from other idiopathic interstitial pneumonias. In conclusion, the investigations for NSIP encompass a multidimensional approach combining laboratory tests, pulmonary function tests, imaging studies, and bronchoalveolar lavage. HRCT, features of nonspecific interstitial pneumonia, or NSIP. First on our list is increased reticular markings. These fine linear opacities are a hallmark feature of NSIP on HRCT scans, indicating interstitial thickening and fibrosis. Next, we encounter traction bronchiectasis. These dilated airways are pulled outward due to fibrotic changes in the lung parenchyma, contributing to the characteristic HRCT appearance of NSIP. Another key feature is lobar volume loss. This asymmetrical reduction in lung volume reflects the destructive nature of NSIP and its impact on lung architecture. But perhaps the most striking finding is ground glass opacification. In NSIP, GGO predominantly manifests in the lower lung zones, creating a characteristic bibasillar pattern. It's important to note that this GGO sparing the subpleural region is particularly emblematic of NSIP. In summary, the HRCT features of NSIP encompass a constellation of findings, including increased reticular markings, traction bronchiectasis, lobar volume loss, and bibacillar ground glass opacification that spares the subpleural region. Let's explore the distinctive histological features that define NSIP under the microscope. First, let's examine the cellular pattern. In NSIP, we often observe mild to moderate interstitial chronic inflammation. This inflammatory response is accompanied by the presence of type 2 pneumocyte hyperplasia in areas of inflammation. In fibrosing pattern. In this pattern, we encounter dense or loose interstitial fibrosis. Unlike usual interstitial pneumonia, NSIP lacks the temporal heterogeneity pattern and patchy features. Upon examination of H&E stain sections, the lung architecture may appear lost. However, with elastin stains, we observe that the lung architecture is relatively preserved. This preservation is a distinctive feature of NSIP, aiding in its differentiation from other interstitial lung diseases. Negative findings. Both patterns. Absence of acute lung injury pattern, especially hyaline membranes. Inconspicuous or absent eosinophils. Inconspicuous or absent granulomas. Absence of viral inclusions and organisms on special stains. Cellular pattern. Absence of dense interstitial fibrosis. Absence or minimal prominence of organizing pneumonia. Absence of diffuse severe alveolar septal inflammation. Fibrosing pattern. Absence or inconspicuous presence of temporal heterogeneity pattern, especially important in cases with patchy involvement and subpleural or paraseptal distribution. Diagnosis: patients with a known connective tissue disease, CTD, and a clinical course and HRCT pattern consistent with NSIP generally do not need a lung biopsy. Who don't have typical findings, definitive diagnosis of NSIP requires histopathologic analysis of a surgical lung biopsy specimen, accompanied by a multidisciplinary assessment when possible. Patients with exposure to agents associated with hypersensitivity pneumonitis, HP, should be evaluated with directed serologic tests, examination of HRCT for features of HP. Initially, NSIP was categorized into 3 groups, primarily distinguished by the presence and extent of interstitial fibrosis. However, subsequent research revealed no significant prognostic variance between groups 2 and 3. As a result, these subgroups were amalgamated into 2 main categories, cellular and fibrotic. Let's break down the treatment strategy for different disease severities. For mild and stable disease, observation is often the recommended course of action. However, in cases of moderate to severe disease characterized by symptoms, impaired pulmonary function tests, and specific HRCT features, initiating treatment with steroids is typically warranted. In more severe cases, a combination approach may be necessary. This can involve steroid therapy alongside immunosuppressive agents. Alternatively, methylprednisolone pulse therapy followed by oral steroids may be considered. The typical dosage of steroids begins with 0.5 to 1.0 mg per kilogram, capped at a maximum of 60 mg daily for the initial month. This is followed by a gradual reduction to 30 to 40 mg daily over the next 2 months, and subsequently, the dosage is tapered off over a period of 6 to 9 months. In cases where patients experience relapses after discontinuation of glucocorticoids, continuing with a low dose or introducing steroid-sparing agents may be necessary. It's crucial to initiate pneumocystis jirovecii prophylaxis concurrently with steroid therapy to prevent opportunistic infections. Immunosuppressants. Azathioprine and mycophenolate mofetil, MMF, are indeed commonly used as first-line immunosuppressive agents. Cyclophosphamide, calcineurin inhibitors, such as Tacrolimus and Cyclosporine, and Rituximab, are often reserved for cases where first-line treatments are not effective. Azathioprine. The typical starting dose of azathioprine is indeed 25 to 50 mg per day, usually taken orally. Then, the dose is gradually increased, usually by 25 to 50 mg increments every 1 to 2 weeks, based on individual response and tolerance. Adverse effects: GI disturbance, nausea, vomiting, diarrhea, or abdominal pain. Bone marrow suppression. One of the most significant potential adverse effects of azathioprine is bone marrow suppression. Regular monitoring of blood counts is necessary to detect and manage this side effect promptly. Infections. Patients taking these medications should be vigilant for signs of infection and may require prophylactic antibiotics or antiviral medications. Mycophenolate mofetil, MMF, is an immunosuppressive medication commonly used in the treatment of various autoimmune diseases. MMF works by inhibiting the proliferation of lymphocytes, particularly T and B lymphocytes. It achieves this by blocking the enzyme inosine monophosphate dehydrogenase, INPDH, which is involved in the synthesis of guanosine nucleotides necessary for DNA replication in lymphocytes. Typically, MMF is initiated at a starting dose of 1 to 1.5 grams per day, divided into 2 doses. Adverse effects: gastrointestinal disturbances, bone marrow suppression, increased susceptibility to infections, risk of malignancy, lymphoma and skin cancers. Cyclophosphamide, in cases where there is evidence of disease progression or resistance to other therapies. Monthly IV infusion is preferred over oral. 3 to 6 months trial is recommended to assess clinical response. Proper prehydration can reduce the risk of hemorrhagic cystitis. Adverse effects: increased susceptibility to infections, gastrointestinal disturbances such as nausea, vomiting, and diarrhea. Bone marrow suppression, risk of infertility, particularly in women. Potential for long-term adverse effects such as bladder toxicity and increased risk of secondary malignancies. Rituximab is a monoclonal antibody medication that targets a specific protein called CD20, which is found on the surface of B lymphocytes. Adverse effects: infusion reactions. Symptoms may include fever, chills, rigors, headache, nausea, and low blood pressure. Premedication with corticosteroids, antihistamines, and acetaminophen can help reduce the risk and severity of infusion reactions. Infections: hypogammaglobulinemia, cardiovascular effects, arrhythmias, myocardial infarction, and heart failure. Hepatitis B, reactivation. Progressive multifocal leukoencephalopathy, PML. A rare and potentially fatal brain infection caused by the JC virus has been reported in patients receiving rituximab. Tacrolimus and cyclosporine, both immunosuppressive medications that belong to the class of calcineurin inhibitors. In NSIP, both may be considered as a second-line or adjunctive therapy in patients who do not respond adequately to corticosteroids or other immunosuppressive agents. Nintedanib. In cases where there is evidence of progressive fibrosis and decline in lung function. Nintedanib exerts its therapeutic effect by inhibiting multiple receptor tyrosine kinases involved in the fibrotic process. When it comes to prognosis, nonspecific interstitial pneumonia, or NSIP, offers a glimmer of hope compared to its counterpart, idiopathic pulmonary fibrosis, or IPF. Fibrotic NSIP presents a graver outlook compared to its cellular counterpart. Stay updated with the latest in medicine. Subscribe to our channel for comprehensive videos covering the latest updates in the field.